the chamber, there, inside the heart chamber. And when this clot is transported from the heart to the brain, because the blood vessels that supply the brain are lower in diameter, it can lead to obstruction. And then we can even have sometimes some conditions where there is an abnormal connection between the right part of the heart and the left part. So like people who have some kind of atrial septal defects. So there's a connection between the right atrium and then the left atrium. So when there is an embolus, when there's a clot in the right atrium, that clot can easily go into the left part of the heart, get transported to the brain, and cause an injury. And even sometimes people who get with pulmonary embolism can even end up having this ischemic stroke. As said, another important factor to consider in ischemic stroke is that there are some people who don't have any of these risk factors, but due to genetics, where there is an inherited disease of the blood vessels, and so the blood vessels end up thickening and reducing flow of blood, and the person end up having ischemia. And such conditions, an example of such condition where we can have this happening is called the Cardinal Syndrome. So the Cardinal, which is cerebral autosomal dominant arteriopathy with subcortical infarct and leukoencephalopathy. So this is a diagram showing the different kinds of stroke that we have. So if you have an obstruction to the flow of blood to the distal part of the blood vessels, which supply some part of the brain, so you end up having what? Death of the tissue, because there's no oxygen, there's no nutrient, and then sometimes you can have the blood bursting in some conditions, especially people who have arteriovenous malformations and people who have aneurysm, that's dilatation of the blood vessels in the brain, and end up rupturing. So there's rupture of the vessels, and the blood causes a toxic effect on the brain, and sometimes when it's massive, it causes increase in intracranial pressure. So this also just to remind ourselves of the different kinds of mechanisms of ischemic stroke, which I have mentioned already. So when we look at the hemorrhagic stroke, and hemorrhagic stroke, as I mentioned earlier, is caused by bleeding directly into or around the brain, and this causes the neurologic symptoms by the toxic effect of the blood, producing the mass effect or the increase in intracranial pressure. So this is the blood. Let's take this to be the blood vessel, and then there's a rupture of maybe a dilatation on a part of the blood vessel. So when this rupture occurs, there's injury to the brain, and this also causes stroke. So some of the causes of hemorrhagic stroke include when there's structural vascular lesions. So structural vascular lesions, as I mentioned, aneurysm, arteriovenous malformation, or even cavernomas. And we can even have medication. So medications such as warfarin or other anticoagulants can lead to hemorrhagic stroke. And we can even have amyloid angiopathy. So this refers to deposition of proteins, specifically amyloid B, in the cell wall of the arteries. So as these proteins begin to build up, they cause weakness on the blood vessel, and this can predispose persons to hemorrhagic stroke. And the most important factor in hemorrhagic stroke is hypertension. Hypertension has been found to cause about 21% of hemorrhagic stroke among all these causes of, among all these causes, summarized as smash shoe. And old age, and the common precipitant, among the common precipitant that can make someone having all these risk factors to have hemorrhagic stroke include the alcohol and then the anticoagulation. So who is at risk of getting stroke? So this can be broadly categorized into two. We have the modifiable risk factors. The modifiable risk factor refers to what you as an individual, you can do something about it in order to reduce the incidence or your chance of getting stroke. So we have high B body mass index. When you are diabetic, hypertension, alcohol consumption, sedentary lifestyle, kidney dysfunction, ambient particulate matter pollution. And in fact, the global burden of disease studies came out with these findings whereby atmospheric conditions has been implicated as a risk factor of stroke. So is it that there's high pollution in Africa, or the increase in temperatures combined with the hypertension is what is causing the high incidence of stroke among us? Let's think about that. And what we can't do anything about, but just to pray to God to deliver us. When we are aging, people who are more than 65 years are at risk of getting stroke, and male sex. And why the male sex at risk of stroke now is something yet to be found. And race, as mentioned, stroke is common among Asia and sub-Saharan Africa, followed by the European countries. And people with certain genetic conditions, such as sickle cell disease, the cerebral amyloid angiopathy, and then the cerebral autosomal dominant arteriopathy with subcortical infarct and leukoencephalopathy. And let me remind us all that, as mentioned earlier, for every 10 people who die of stroke, 4 could have been saved if their blood pressure had been controlled. So as doctors, as nurses, or anyone joining us, let's pay very good attention to our blood pressures. The clinical manifestation of stroke actually depends on the part of the brain that is affected. So the brain as an organ is full of mysteries. Every part has its unique blood supply, and every part also has its unique role. And sometimes someone can even have a stroke and without you as a clinician picking it up because of how mysterious the brain is. So let's remind ourselves of the various functions of the brain. So the brain is divided into 3 main parts. We have the forebrain, the midbrain, and the hindbrain. The forebrain, most of it consists of the cerebral hemisphere. And in the cerebral hemisphere, we have the frontal lobe, we have the parietal lobe, we have the temporal lobe, and then the occipital lobe. So the frontal lobe contains a part that controls our movement, which is called the primary motor cortex. As you can see the pointer going, the primary motor cortex. And this is responsible for voluntary muscles. While the parietal lobe also contains the part that makes us to be able to sense that something is pricking us or there is danger impending on our body. So inside we will have the sensation, and then language, perception, or body awareness or attention. And then what is making us see what is happening right now is the function of the occipital lobe. So the occipital lobe is responsible for the sense of vision. And then when we have, and on the temporal lobe, which plays important part in speech or language. So actually speech production and understanding is always a coordinating, it's a result of a coordination between the frontal lobe and the occipital lobe. So the part of the frontal lobe helps in making sounds. It's called the bronchus area. The bronchus area. And then when someone speaks, for you to be able to understand what the person has said, is controlled by a part of the temporal lobe, which is called the Wernicke's area. And if you go deep into anatomy of the brain, there is always a connection between the bronchus area and the Wernicke's area, and this is called the arcuate fasciculus. So the temporal lobe is also responsible, apart from its role in speech, is also involved in memory and language. And when we come to the brainstem, in fact, that's where we have a lot of the cranial nerves. And this plays very important role in regulation of even our heart rate and breathing, as well as our consciousness. The hindbrain, which also contains the cerebellum, enables us to really maintain our posture. I did not with the cerebellum when we will even easily be carried away by the wind, not knowing our left and right. But thanks to cerebellum, maintaining posture, balance, and coordination of movement. So for you to be able to diagnose someone with stroke is purely clinical, supported by imaging and certain labs. So a careful history and neurological examination can often localize the region of brain dysfunction. So depending on the type of the blood vessel which is affected, so we can have three major categories of stroke, which we refer to as the stroke syndromes. So we have the stroke vessel, the large vessel stroke within the anterior circulation, the large vessel within the posterior circulation, and each of these vessels tend to also give a very minute blood vessel to supply other important parts of the brain. So these are called the small vessel disease. And such vessels are the ones that conditions such as lipohyalinosis can affect. So as you can see on the screen, this is how the heart and in the brain interact in terms of blood vessel supply. So the brain is supplied by two main pairs of arteries. We have the internal carotid artery and then the vertebral artery. So if there's the heart, this is the blood vessel, the left ventricle, that's my pointer is showing. And from the left ventricle, we have a very large artery carrying oxygen and nutrient to supply the various parts of the heart. And right at the arch of the aorta, on top of the aorta, we have three main blood vessels: the brachiocephalic trunk, the left common carotid artery, and the left subclavian artery. So the brachiocephalic trunk, which supply the right side of your body, gives off two main blood vessels. So we have the right common carotid, and we also have the right vertebral artery. So from the right common carotid, we have the right internal carotid artery, and then the vertebral artery, which comes off from the subclavian artery, goes directly and joins the other vertebral artery, the left vertebral artery, to form a common conference, which is called the basilar artery. So the internal carotid artery, together with 8 branches, forms what we call the anterior circulation. So as I mentioned, that we can have the large vessel within anterior circulation, the large vessel within the posterior circulation. So the internal carotid artery gives off branches, which include the middle cerebral artery. So there's a cut part or the inferior view of the brain. So there's the internal carotid artery. Gives out 2 main branches, which is the middle cerebral artery, and then we have the anterior cerebral artery. And this constitutes the anterior circulation. So we have the internal carotid artery on either side. So, and each anterior cerebral artery there is a connection between the 2 anterior cerebral arteries, which is called the anterior communicating artery. So the vertebral artery that we saw coming from the subclavian arteries on either side of the body, as mentioned earlier, will join together to form the basilar artery. And then the basilar artery also gives off 2 branches we call the posterior cerebral arteries. So the posterior cerebral arteries is connected to the middle cerebral artery on either side, which we call the posterior communicating artery. So this ends up forming a circle. So a circle whereby we have the anterior circulation joined by the posterior circulation. So and the circle is popularly known as the circle of Willis. This is serve as a very important rule in such a way that if there's a blockade to one part of the brain, sometimes there can be the compensation by the other communicating artery so that there wouldn't be much effect. So now, as we all know, the various function of the part of the brain and the blood supply to the different parts of the brain. It's also important to know that, as I mentioned, every part of the brain has its own unique function. So there's a diagram showing that on the brain, we have some representation, we have body part representation on every part of the brain. So we have the face, which occupies the parietal lobe of the brain, and we also have the foot, which occupies the genu, or the genu of the foot, which occupies this part of the brain, as well as the hand, and we also have the bowel, and even the urinary bladder being controlled by this part of the brain. And this also gives us more insight into how the perforating branches of the major arteries that supply the brain end up into. So we can have this what we call the hello, please, can you hear me?
Yeah, Michael, we can hear you loud and clear.
Please, can you hear me?
We can hear you loud and clear. Please go.
Okay. So it's like if you take the middle cerebral artery, we have the proximal and then we have the distal part. So the proximal middle cerebral artery is most often the proximal middle cerebral artery gives rise to the penetrating branches. So this is the penetrating branches, which we call the lenticulate striate artery. And this supply the basal ganglia, which consists of the putamen, the globus pallidus, and then the caudate nucleus. And then if you go inside the Sylvian fissure, we also have some part of the middle cerebral artery. And in most people divide into, we have the superior and then the inferior divisions. So the superior division in some books is mentioned as the M1 branches and the inferior as the M2 branches. So if we have the inferior division supply the inferior parietal and the temporal cortex, as you can see from here. And then the superior division supply the frontal and the superior parietal cortex. So if you have the entire middle cerebral artery being occluded at its origin, I mean from here, origin, it means the penetrating and the cortical branches will also be cut off. So as you can see from here, with the various representations of the body part, when there's a cutoff in blood supply to these regions, you end up having hemiplegia, that the person is not able to control the part, I mean the limbs, the arms, and then the legs on the opposite side of the brain, which is affected. And then the person will not also be able to sense whether temperature or pain on the part of the body which is affected. And then the middle cerebral artery also supply the nerves which is involved in eye movement. So when the middle cerebral artery is affected, you see that the eyeball tends to move towards, if it's the right part of the body, the right part of the middle cerebral artery which is affected, you see that there is a preferential gaze. You see the eyeball move towards the part of the brain which is affected, because the other part of the brain which is supposed to also counteract the pulling effect on the part of the brain is absent. So we tend to have a preferential gaze. So with this information, so if you are struggling to find out where in the lesion of the brain which is affected, look into the eyes. The patient himself or herself is telling you it is part of my brain which is affected. And people with middle cerebral artery occlusion or hemorrhage also tend to have dysarthria, and there's also facial weakness. So and let me be quick to add that the two hemispheres, we have the dominant and then the non-dominant hemisphere. So in right-handed people, the dominant hemisphere tends to be on the left part of the brain, or the left hemisphere. So the dominant hemisphere contains the part which controls your speech. So a right-handed person who have occlusion of the left cerebral artery will have speech problems with speech production and as well as understanding. So we have something we call the global aphasia. But when the lesion affects the non-dominant hemisphere, patients tend to have neglect, hemi-neglect. So the hemi-neglect may not necessarily mean that the part is affected. Sometimes the person even forget that he has this part of his body which is supposed to function, and may not necessarily mean a weakness. And we can even have anosognosia. Sometimes the person does not even know what is going on around. And we can even have constructional aphasia. You ask the person to draw something, the person actually understands what you are asking him to draw, but the willingness to even draw is a problem. So this is about complete cerebral artery occlusion. But sometimes we can even have partial syndromes, and these are due to embolic occlusion of a single branch. So, for instance, we can have the hand or the arm weakness alone, which we call the Broca's syndrome, or the facial weakness with no facial weakness, where the person is not able to produce only speech, but other parts of the body are functioning well, and all it's all because of when there is decreased blood supply to the frontal lobe, which is involved in the speech production. So sometimes we can even have a combination of sensory disturbance as well as motor weakness and even non-fluent aphasia. And this, as mentioned earlier, describes more of an embolus than an atherosclerosis going on, because the embolus end up occluding the minute blood vessels that supply specific parts of the body. So, assuming there is a defect in the temporal lobe, the superior temporal lobe, which is responsible for speech comprehension. So we have something we call the Wendy's aphasia. So, and this one is supplied by the inferior division of the middle cerebral artery of the dominant hemisphere. So in such situation, the person cannot understand, but the part of the brain which produces speech is intact. So such people end up making sounds that do not make sense to you, the listener. So they will describe that they are saying jargons. What they are saying doesn't make sense, but such people, to when you also speak to them, they can't mix it. Because they don't understand what you are saying to them, they are also in their own world giving you their own answers, which you also don't understand. So looking at how deep the anatomy of the brain is, if you say that we should take every blood vessel, its cause and how a defect will lead to a particular deficiency, or how symptoms and signs will come about, I'm not sure we will leave this session. So this is just a summary of what will also appear to someone who has either an ischemia, maybe a thrombosis or infarction, or even sometimes, or most of the times, when there is a hemorrhage on the part of the body. So if you have the posterior cerebral artery being occluded, so there is also on the dominant hemisphere, we have aphasia, motor and sensory deficit, and this tends to affect the face, the arm, and then the leg compared to the foot. And then there can be either a complete hemiplegia, because the posterior cerebral artery also supplies the internal capsules. And then we can even have the internal. So if you have a complete occlusion of the internal carotid artery, it means the function of the middle cerebral artery and the anterior cerebral artery will be off. So you tend to have these symptoms. So how do you tackle stroke? In fact, management of stroke starts from the house. And what are you to do in the house is the most first response is recognition. Most people who suffer from stroke are not even aware of what has happened to them or what is happening to them. So most of the time, when family members or friends are around, they are the ones who are to pick the signs and symptoms. So a quick reminder is to act fast, recognize and act fast. So FAST itself should be an acronym. So F for facial drooping, weakness in the arm, ask the person to raise the arm. If you notice that there is asymmetry of the face, ask the person to raise the arm, and then you realize that one arm is weak compared to the other. So, and then you realize that there's also a change in the speech production. And then when you see all these three symptoms, it's time to call the ambulance. And even sometimes, some people even think that the acting fast in itself is not okay, but look for other signs which made up of to make it up faster. So sometimes it's not only about the face, the arms, and then the speech that you should watch. Sometimes people can even have difficult in seeing or even dropping on one part, one eyelid, or they may even complain to you that all of a sudden they are unable to see. A person can even start having dizziness or keeping balance or even loss of coordination. And then if my memory serves right, these are important signs of cerebellar lesion. The cerebellum, it means the cerebellum is affected. So if you see all these things, call the national ambulance to act fast because time is brain. So once the ambulance has come to the hospital, we as clinicians also have to act fast. So this has to do with what? Taking history, examination within 10 minutes. And then right from there, we have to move person for one important investigation, which is the CT scan. So most of the time, places where systems are well in place, we have the stroke response team, and they are taught how to act fast and not to waste time. Sometimes we see some people using 30 minutes, 1 hour to take histories. At that time is brain. We are releasing precious tissues of the brain. So when there's a sudden onset of brain function is a core feature of the onset of stroke. So once the patient is in the hospital, ensure that patient is medically stable before moving patient for any kind of investigation, especially the three most important investigation or things to do before moving a patient for any other important investigation is to check the airway, the breathing, the circulation, sugar, and temperatures. And then look out for any red flag symptoms that is happening in this person and see if it can be reversed. And then determine, based on your history and examination, whether this is an ischemic stroke and if the person is a candidate for intravenous thrombolytic, if it's an ischemic stroke. So sometimes we can have the stroke happening and we can even have some tissue dying. But the most important aspect in managing stroke patients in the hospital is to rescue the part of the brain which is dying, not the dead part of the brain. So the part of the brain which is dying or at risk of death is called the ischemic penumbra. So this is the time. This is the part that we are making all our efforts to save so that patient will have very little disability. So look out for red flag symptoms that can adversely affect brain injury, such as hyperglycemia, temperature, and even hypoxia. So in managing hypoxia, look out for the patient's airway. Some people are unable to breathe especially when we have brainstem lesions. So they tend to even desaturate. And then sometimes people who are unable to swallow may even end up aspirating. So we can even have aspiration pneumonitis. So it's time to do suctioning, listen to the chest, see if there can be a means of ventilating and improving oxygen supply or saturation. And then also check for the circulation, most importantly, blood pressures. So as I mentioned, hypoglycemia and hyperglycemia, one of the most important investigations in acute management of stroke. And then when you have performed all this and see that patient is stable, the next most important investigation is to do a non-contrast CT scan. This is to make you to have full confidence that this is really ischemic stroke or hemorrhagic stroke. And in fact, there are no reliable findings that can conclusively separate ischemia from hemorrhage. As in the past period, people say that sometimes when person present with sudden onset of headache and then with weakness on the part of the body with associated vomiting, it tends to favor hemorrhage. But several research have come out and dozens of support sets clinical distinction between these two types of stroke. But however, in places where you think you can't have access to CT scan, sometimes you can use this judgment. Is the person level of consciousness decrease? What's the blood pressure? So most of the time, high blood pressure, decreased level of consciousness, and worsening of symptoms after the acute onset tend to favor hemorrhagic stroke than the ischemic stroke, which tend to occur over a period of time. Or sometimes there's a maximal onset, and then all of you realize that the person start to improve as a result of the improve in perfusion. So when someone has a stroke, the medical management can be categorized into 6 main processes: medical support, thrombolysis, antithrombotic, neuroprotection, and when things are sorted out, move patient to stroke centers and rehabilitation. So in airway protection or ventilation, as mentioned earlier, people who come in with decreased level of consciousness and then raised intracranial pressure due to hemorrhagic stroke, and sometimes vertebrobasilar ischemia and bihemispheric ischemia, they tend to have depressed level of saturation and need to be supported. And we must almost always maintain saturation above 94%. And as mentioned earlier, people with stroke tend to even have deficit in swallowing and are at risk of aspiration pneumonitis. So it is important that anyone who comes to the emergency with stroke, swallowing assessment need to be done to see the need for passing of NG2 or not. And then the next one is blood pressure management. So people who are not candidates for thrombolytic therapy, in fact, should not have, most of the time, people with ischemic stroke come in with very high blood pressures, which don't really understand or don't get the pathophysiology well. You may be quick to lower blood pressure because as the blood pressure is stirring your eyes, it's also causing you palpitation. But in ischemic stroke, we are not in hurry to lower blood pressures, especially below 160/110. So people ask, if you are not ready to offer thrombolytic therapy, you don't have to rush to give antihypertensive unless the BP is more than 220/120 millimeters per mercury, because the high blood pressure in itself is a response. It's a response in order to improve perfusion to the brain. So to maintain the cerebral perfusion pressure. But however, there are exceptions where blood pressure will need to be dropped drastically, especially people with active ischemic coronary disease from ECG, people with heart failure, aortic dissection, hypertensive encephalopathy, pre-eclampsia, and eclampsia. That one, you don't wait. But in times where you need to lower blood pressure, it is important to reduce it by 15% during the first 24 hours, and then gradually within a few days to a week. And then the most important, and then we have to be careful on the kind of antihypertensive that we give. Nifedipine is contraindicated in management of blood pressure in people with stroke, or because nifedipine tend to cause a drastic fall in blood pressure, and this drastic fall tend to maintain for quite a longer time compared to these first lines, labetalol, nicardipine, and clevidipine. And in situations where you don't have labetalol, nicardipine, or clevidipine, the next option is nitroprusside. But when patient is being prepared for thrombolysis, that's radiological intervention in order to remove a thrombus or a blood clot in order to restore perfusion to the brain. So in a situation where such procedure is going to be carried out, you must ensure that BP is always below or equal to 180/110. And this must maintain for at least 24 hours after the procedure. If BP is never equal or less than this, the person is not a candidate for thrombolysis. But in both subarachnoid hemorrhage as well as intracerebral hemorrhage, the approach to BP control must take into account the potential benefits and risks. So people with severely elevated blood pressure can have worsening symptoms. And if this one continues or is recurrent, it can rather lead to a fatal outcome. Because sometimes the bleeding itself incites or cause continuous bleeding, and this leads to hemorrhage expansion and potentially worse outcome. So lowering BP rapidly will also cause further injury by promoting cerebral and systemic hypoperfusion. But in situations where you need to reduce blood pressure drastically, especially where we have intracerebral hemorrhage, it is important to maintain BP between 150 to 220 millimeters, and then to a target of 140 of systolic blood pressures. And then labetalol also appears to be the first line drug, especially for BPs less than 160. But if systolic blood pressure is more than 220 on presentation, we need to act fast. And the drug of choice is nicardipine. And this blood pressure must be reduced gradually over a period of hours to a target range of 140 to 160. So And it's important to be monitoring BP for at least every 15 minutes to see whether a person will need further management or a stop to antihypertensive be put in place. So apart from clopidogrel and nicardipine, other important drugs that can also be used include clofazimine, ismolol, and enalapilat, and then phenoldupan. We can't afford to always reiterate the importance of blood sugar in management of stroke. So sometimes people with stroke even come in with hypoglycemia, and hypoglycemia even is one of the important mimics of stroke. People with hypoglycemia can come and present with signs and symptoms of stroke. So checking sugar and correcting them may even end up you correcting the underlying condition and may save patients from other complications. And hyperglycemia, as mentioned, is common in patients with stroke and is associated with poor functional outcome. And the American Heart Association, together with the American Stroke Association, recommend treatment of hyperglycemia to achieve glucose level between 7.8 to 10.0. So you don't want so much sugar, and also don't want to reduce sugar below 7.8. And then the European Stroke Initiative also recommend keeping glucose levels less than 10 millimoles per liter. And several trials have been conducted to see whether intensive sugar control using the insulin infusion or the sliding scale. But I realized that the SHINE trial came out that intensive glucose control with the insulin infusion tend to have some worse outcomes. However, even though the mortality between the sliding scale and the insulin infusion scale, the insulin infusion there wasn't much difference between the two, but the intensive insulin infusion tend to have worse outcome compared to the sliding scale. So the sliding scale is preferable in management of hyperglycemia. Temperature control, also very, very important, because hyperthermia in itself tend to have very worse outcomes in people with stroke, all through this mechanism. So high body temperature increases the release of neurotransmitters and also increases the production of oxygen-free radicals. And this increase of oxygen-free radicals leads to breakdown of the blood-brain barrier. And then when this occurs, people tend to have impaired recovery or even energy metabolism. And then this in turn reduces protein kinases, the activity of protein kinases, which are very important in metabolism. So all these processes end up having worse outcomes in people with stroke. So in management of temperature, it is important to, first of all, identify the source. Many people with stroke also have urinary tract infection, or sometimes even aspiration pneumonia is a very important source of hyperthermia. So looking for the source of the hyperthermia, especially the underlying cause, and treating it with analgesics, such as paracetamol. Very important. And then, as mentioned earlier, hyperthermia in itself increases mortality rates, tend to cause more dependence even when the person survives the stroke, and tend to have poor functional outcomes. And then people, even if person will need to be stayed, they tend to let patients to stay long in the hospitals. So as mentioned earlier, investigate and treat the source of the fever, aspiration pneumonia, malaria, and UTI, malaria especially in our setting, and then treating it maximum paracetamol with a maximum dose of 4 grams per day. It is not surprising that people with stroke even come in with hypovolemia. So, assessing for hydration in people with stroke during the acute phase cannot be overemphasized. So, intravascular fluid depletion and more frequently the symptoms of acute stroke, particularly in adult patients, tend to worsen cerebral perfusion. And the choice of fluid in management of stroke is isotonic saline or normal saline, because apart from this, no other is recommended, because giving dextrose saline or Wenger's lactate in itself tend to cause more injury to the brain, because the sugar content in dextrose saline in itself, as mentioned in the management of hyperglycemia, how glucose can be toxic to the brain. So my monitoring fluid input and output must also be part of the initial management, or even sometimes the long term. So when you have made, so as you are trying to stabilize the person, your history taking is also going on. So as I mentioned, taking of history and stabilizing patient should be done within 10 minutes of arrival at the emergency. So in taking a history, you are focusing on the time of onset of the symptom. The time of onset of the symptom. And then sometimes patients or even patient relatives may not even know the time, because there are some people who even wake up having stroke. So how do you determine the time of onset? So you ask the person, when was the last time that the person was seen normal? When was the last time that the person was seen normal? And that will give you a clue. And this time is very important in that it gives you an idea whether this person has a window of opportunity for thrombolysis or not. And then the cause of symptoms over time. Did it happen drastically or all of a sudden, or did the person improve over time? And this can even give you whether this can be from an embolic source, and it's also important to rule out head injury as of recent trauma. And sometimes, as I mentioned, patients who come in with hypoglycemia can even have signs and symptoms making stroke, and also as of whether person has history of epilepsy or use of anticoagulant drugs. It can give you a clue of hemorrhagic stroke. So combining the history and the examination, the National Institute of Health also comes out with a scale which is composed of 11 items, and with which you can use to determine whether this is a mild disease, a moderate disease, or a severe disease. So people who tend to have less than 5 score are categorized as with mild disease, between 5 and 9, moderate, and then more than 10 as severe. And then the 3 most predictive examination findings for the diagnosis of acute stroke are facial paresis, look at the face, the arm drift or weakness, and then the abnormal speech. And then the NIST score on admission has also been correlated to the outcome of someone with stroke. So as I mentioned earlier, the 3 most important investigations in the acute management of stroke: check for saturation, check for blood sugar, and do a head contrast CT scan. Even though other important investigations may be required, such as ECG, fasting, full blood count, and protein profile, these 3 should not prevent you from moving patients to do a contrast CT or MRI and starting with thrombolysis in the case of ischemic stroke. They are important, all right, but these three are the most important. So person, we are stabilized patient, a person has done the CT scan. So we analyze the CT scan. So can see some young doctors try to appreciate the lesions that this person is having on his head CT scan. So this person, is he really pointing correctly at the lesion? I think yes. So actually this is a CT scan. There is a big infarct around the temporal parietal region on the right part, on the right hemisphere. So this person will end up having left hemiplegia or hemiparesis or sensory loss. And then the speech will also be impaired. And then you also determine whether this person is also having hemorrhagic. So this is how ischemic stroke looks on a CT scan, and this, so a hypodense lesion, and then hemorrhagic stroke appear hyperdense. So you compare with the color of the scar, white. So the scar appear white on the CT scan, and blood also appear white. Apart from that, people with contrast can also tend to have whiteness on other, especially in the CSF. So any white lesion you see on any part of the stroke, on any part of the brain, should be interpreted as well hemorrhagic lesion. So just find ourselves hemorrhagic stroke, ischemic stroke. So we've already mentioned the processes to go through. This is just a summary. So identify the lesion, call the ambulance. When person comes to the hospital, within 10 minutes of arrival, all interventions, including history taking, blood sugar checking, and everything has been done within 10 minutes. Within 10 minutes, call the stroke team. And then within 20 minutes, the stroke team, 20 minutes refers to time of stroke onset, time of arrival, but not that the stroke team will take 20 minutes to evaluate. So within 20 minutes on arrival, stroke team will have finished their evaluation and determine and interpret this CT scan within 45 minutes. And all these times are put in place in order to ensure that persons with ischemic stroke tend to have intervention such as thrombolysis within 3 hours of arrival, because it has been researched that between 3 and 4.5 hours, that's really the appropriate time where thrombolysis can be done in order to salvage tissue from dying. And then if person is qualified for thrombolysis, we say we give this within 60 minutes. And this, as we see very soon, thrombolysis is given in two separate doses. We have the bolus, which must be given within 60 seconds, and then the others, and then the next dose given within 60 minutes. So if person is not qualified for thrombolysis, then it's time to start with your aspirin. But if CT scan shows that there's a bleed, it's important to consult neurologists, and then neurologists will determine whether person will need neurosurgeon intervention or not, or will need to continue to manage conservatively. So thrombolysis as part of reperfusion therapy as part of management of ischemic stroke. So the most important factor in successful reperfusion therapy of acute ischemic stroke is early treatment, as I said. So between 3 and 4.5 hours after onset of symptoms. And the immediate goal of reperfusion therapy in ischemic stroke is to restore blood flow to the ischemic regions not yet infected. So this refers to the penumbra regions. And then the long term is to improve the outcome by reducing the stroke-related disability and mortality. So intravenous thrombolysis, we have the altiplase and then the tenecteplase. So, and this one tends to is used for smaller blood vessels. But for large blood vessels, we tend to use the mechanical thrombectomy, which has to do with radiologist intervention. So who is qualified for reperfusion therapy or intravenous thrombolysis? So someone with the clinical diagnosis of ischemic stroke with CT scan, we supported with CT scan, and then the onset of symptoms less than 4.5 hours. And then people who are more than 18 years. And then when CT scan show no evidence of hemorrhage or edema, more than 1/3 of the middle cerebral artery territory on the CT. However, people with ischemic stroke or severe head trauma in the previous 3 months are excluded. And other exclusion criteria include when there's a history of previous intracranial hemorrhage, people with gastrointestinal bleeding, people with BP persistently more than 85/110, or people who are having active internal bleeding. So when in the absence of CT scan, when we have symptoms and signs suggestive of subarachnoid hemorrhage, or when person has a history of recent or current use of anticoagulants. In the treatment of stroke, time is brain. The sooner intravenous thrombolysis is initiated, the better, or the more likely it is to be beneficial. Acetazolamide is given 0.9 milligram per kg with a maximum dose of 90 milligrams. So given over 60 minutes, 10% of this 0.9 milligram per kg is given as bolus over 60 seconds or 1 minute, and then the rest over 1 hour. So if you don't have altiplase, the next one is the tenecteplase. So as I made mention, mechanical thrombectomy, which is usually used for large vessel infarct or clots occluding large vessels. So this one requires a radiologist intervention where there is a wire. So the wire is passed through. It passes through the femora and it's guided through all the way to the brain. So in order to catch the clot and then evacuate it. And then this has a longer window period compared to intravenous thrombolysis. You have a window period of up to 24 hours. A window period of up to 24 hours in order to start. And then we also have sometimes, even before we can even start with the intravenous, with the mechanical thrombectomy, sometimes we can give the intravenous thrombolysis, and this is referred to as the bridging therapy. And the bridging therapy also comes with its own advantages and disadvantages. So one advantage is that when there's a complete or partial, the IVT, when given initially, can lead to complete or partial lysis. Sometimes there can be delay in time in order to start the main thing which is occurring. And then sometimes when there's even partial lysis of the thrombus, we can have emboli into distal part of the brain, and it's also problematic and can even worsen the stroke symptoms. So, however, when all this have been set in place, you have to continue management. So when IVT or mechanical thrombectomy has been initiated, we continue to manage patients, especially with ischemic stroke, with aspirin. So people who are not candidates for reperfusion therapy, it is recommended that aspirin should be initiated within 48 hours of stroke onset. So, and we cannot overemphasize the debilitating effect of DVT and pulmonary embolism in patients with stroke. So prophylaxis, very important. And high statin therapy, whether patient is on or not, irrespective of the lipid level of the patient, it is recommended. High statin therapy has been found to be very beneficial in people with ischemic stroke. And BP reduction after the acute phase has passed. Intracerebral hemorrhage or hemorrhagic stroke is the deadliest stroke among all. So far, from January to this month, it's only 2 people that I have seen survive hemorrhagic stroke. All the others have really passed on because they tend to come in very severe disease. So in the management of hemorrhagic stroke, immediate attention to blood pressure, airway, as in the ABC mentioned. And it's also important that sometimes hemorrhagic stroke can be caused by people taking anticoagulants. So as for drug history, is a person on vitamin K antagonist, such as warfarin. So in that case, it's important to initiate prothrombin complex concentrate plus vitamin K in order to reverse the effect of this vitamin K antagonist. Or sometimes when you don't have the prothrombin complex concentrate, the other option is fresh frozen plasma. However, one disadvantage of the FFP is that you need large quantities for the FFP in order to reverse the effect of VKA, and that also tends to prolong the time for the reversal. Patients with factor 10A, that will start diabetic can also be reversed with the either with Suzuma. 2 doses of it is enough. People with thrombocytopenia, hematological disease such as thrombocytopenia, fresh frozen plasma, or fresh platelets can also be very helpful. So this is a hemorrhagic stroke, which is being appreciated by my hardworking nurses in my department. So my and everyone in charge showing us where the hemorrhage is. And then this nurse really appreciates it. So I'm sure he's still analyzing where the hemorrhagic stroke is. So is there any difference between these 2 CT scans? Of course. So one is worse than the other. So this one, even though this one, first difference is that this one is occurring on the left hemisphere and this one is occurring on the right hemisphere. And we can see that this is larger, the clot here is larger than this. And this large clot is even causing a pressure effect. So there's a midline shift. So it is even pushing this part of the brain towards the other half. So this is the central sulcus. So this part has gone beyond the central sulcus. So we call it the midline shift. So when there's a midline shift, it tends to have patients at risk of having raised intracranial pressure. And raised intracranial pressure, as we saw, can be due to the mass effect of the initial hematoma. There can even be an expansion or rebleeding of the intracerebral hemorrhage. Edema around the hemorrhage itself can increase intracranial pressure. And then sometimes there can even be outflow obstruction to the cerebrospinal fluid, especially when the hemorrhage occurs at the brainstem, and the person can end up having hydrocephalus. So sometimes it's also important to use our clinical judgment to be able to pick up hemorrhagic stroke as early as possible. Look at the pupils. Is there any defect in the cranial nerve, especially the abducens nerve, and then whether there's diplopia? If patients continue to have worsening drowsiness, or the Cushing trial, is there persistent hypertension, altered respiration, or bradycardia? All these is simply made up of the Cushing trial, and look also for focal signs of herniation. So when we identify that there's increase in the cranial pressure in people with hemorrhagic stroke, our first line of intervention include the use of hypertenuse line or monitor. And then sometimes we can even have the hemorrhagic stroke, which may need surgical intervention. But most of the times, hemorrhagic stroke is managed medically, because there are a lot of studies that have compared medical management and surgical management for hemorrhagic stroke, apart from outside these exceptions, where they realize that the approach of surgery tend to have worse outcomes compared to medical. However, the disease itself is associated with worse outcome. So people with worsening neurological status, hemorrhage causing midline shift, as we saw earlier, or when there is a hematoma at the cerebellum more than 3 centimeters and causing hydrocephalus, or when we have a cross volume between 20 to 80 months, that may need an early neurosurgery intervention. So sometimes it's not the stroke that kills the patient, but it's the complications associated with the stroke that kills the patient. So some of the common complications: aspiration pneumonia, urinary tract infection, deep vein thrombosis cannot be overemphasized. We can't overemphasize how we as clinicians should avoid these three, especially deep vein thrombosis. So patient may even end up dying of pulmonary embolism, which, because the person has a CT scan showing stroke, you may think it's a stroke. No, it's an embolism that killed the person, not a stroke. So it's important to avoid dehydration, regular turning of patient to avoid pressure sores, which can even serve as a source of infection. And then management of orthopedic complications and contractures, initiating early physiotherapy, and then looking for the consult of nutritionists in order to avoid malnutrition. So in summary, the whole of this session has made us to understand the current definition of stroke, and then its types, and then how stroke is increasingly becoming a burden on this world, and then the risk factors and causes of the various types of stroke. And we also give a brief pathophysiology of the various types of stroke, and then how to identify early signs of stroke, pre-hospital, hospital, and inpatient management of stroke. And we can't overemphasize that when it comes to the brain, time is of essence. Let's use time to save the brain. And conclusion, I was going to conclude my presentation with this theme for this year's World Stroke celebration. As the brain tissue and millions of neurons begin to fade away, time could not be more precious. So let's use minutes to save lives, learn the signs and symptoms of a stroke, report early, and let's join the movement to avoid stroke. These are my references. Thank you. And these are
Great. Wow. That was super. Like the theme for this year says, don't be the one. So obviously, I will not want to be the one. I'm sure Dr. Michael will want to be the one. But we are glad that you've been the one to join us for this presentation. I would put in the settings say that you just kindly raise up your hand electronically if you have a question, you have a suggestion, you have some great insights into stroke management, or you want to share a personal story or any of such that will make this presentation richer. Kindly electronically raise up your hand. I would unmute you to do such. But like you would agree with me, Dr. Michael did a fantastic job, and I've learned a lot personally. I've revised a lot, and I'm sure this will serve to educate all of us to sort of re-emphasize on the important aspects of stroke, and more importantly, to create the awareness of the fact that stroke is for real. The modifiable risk factors are there. The number one cause in our country, hypertension, we need to look at critically. So as we wait for comments or anyone who put up the hand to be electronically unmuted, I will take in the, okay, we have someone whose hand is up. Prince Ray, kindly unmute yourself and then go ahead to give us your insights. Thank you. Yes,
hello,
Prince
please,
Ray, you
can
are
you hear
unmuted.
me?
Please go ahead. Yes.
Hello, please, can you hear me?
Yes, please, go
Please,
ahead.
I want to find out, I have a client who just arrived from the house with weakness in the right upper limb. And on history taken, it was realized that he fell in the bathroom that morning. But maybe that person was put in bed around 11 o'clock, and as at maybe 3 p.m., the weakness is worsening. What should we do when the person comes initially, at the initial stage? What should we do to be able to reverse something of that sort, or it's not reversible?
Dr. Michael.
Hello.
Yes, we can hear
Hello.
you now. Go ahead. Yes.
Please, sorry, pardon me, I went off. So can you repeat the question so that I see how?
Yeah, what I was trying to ask is that a client reported to the facility with right upper limb weakness. And on history taken, this client was said to have fallen in the bathroom. But as at 11 a.m. that the person arrived, you put the person to bed, you realize the BP was quite high, but because you don't know the history and you are suspecting stroke, you did not give any antihypertensive. And the BP was getting under control. But as at around 3 p.m., the weakness was getting worsening. So I'm asking, when such a case comes, is there anything to do initially to reverse the weakness, or it is not reversible? And what accounts for the progressive weakness? Because it looks so fast to me.
Okay. Thank you. So as I said, in the pathophysiology of stroke, so let's also come in. Sometimes it's also important to rule out other underlying conditions. Okay. So someone with progressive weakness, it's important to ask yourself, can it be cerebral toxoplasmosis? Okay. Or stroke itself? Okay. And another thing you also have to ask yourself, a probable cause for, apart from cerebral toxoplasmosis, another probable explanation for this occurrence can be more of like an embolic stroke, which is called that, like when we have an atherooma, which dislodges and tend to cause tend to cause distal occlusion of the cerebral vessels or a rapidly expanding atheroма. You know, when we in arterial sclerosis, once the atheroma is disrupted, it leads to a collection of blood or thrombus around it, and that can cause progressive weakness until there's total occlusion where this weakness may be stable. So, as mentioned earlier, there is a cutoff limit where you can accommodate increasing blood pressures. So, as I said, patients with blood pressures more than 220 over 110, 120, you have to intervene with the Labetalol, because the hypertension in itself can even worsen the stroke symptoms. So it's important when persons having BPs as high as 220 over 110, you need to intervene, not with the calcium channel blockers, but also with the Labetalol, the clevidipine, and then the others that were mentioned. So you don't make the patient to continue to have this increasing heart pressures and worsening symptoms. And as well as, so far you don't know whether it is hemorrhagic or ischemic, you still have to avoid the anticoagulation. Or possibly you have to refer for a head CT scan to be done to know what exactly to do.
Okay, all right, thank you very much.
Great. So Dr. Prince, are you done or you have a follow-up?
I'm done. Thank you very much.
All right. Okay, thanks. Yeah. So Dr. Nabil's hand is up. Dr. Nabil, please. Oh, sorry. Let me. Just a minute. Yes, Dr. Nabil, please unmute yourself and go ahead.
Yeah, no. Thank you very much, boss, for the opportunity, and good afternoon to everyone. Yeah, first I would like to commend the presenter. I think it was a very good presentation. I enjoyed listening to him and I learned a lot. I just want to share a few thoughts with the house. First, I want to make a quick observation, probably with regards to the questions being asked. You know, I observed over the past few presentations that sometimes participants want to share with us clinical scenarios and hope that they can get some guidance on it. I just want to make a suggestion that with some of these things, in order to get a proper input, we need more information. So once Dr. Akatiba is available, there are other senior doctors in the region. Maybe you can call them. Maybe these calls can be made rather than discussing them after the presentation, because there's very little information made available to have a proper discussion on those clinical scenarios. And my fear is that the responses that may be given may not be sufficient in dealing with the cases. So like the first question that was asked regarding the patient who presented with progressive, I don't know if it's monoparesis he was trying to describe. You know, you need a bit more information to really go into the case. And the opportunity given may not be adequate for that. So maybe you can call the presenter or get in touch with Dr. Akatiba himself so that there'll be proper guidance. I think it will serve us better, you know. But then the other observations I want to make, one has to do with the prevention of stroke. I think the prevention of stroke cannot be overemphasized. You know, it's extremely important because we all know the prognosis of stroke. Sometimes there's very little you can do, even if the patient survives. You know, the deficits they'll go home with are really terrible. So stroke prevention, very, very important. You know, so let's continue to counsel and encourage our patients to be compliant on their medication. You know, like we know, it's better to prevent than to cure. So stroke prevention for some of us is so key, especially in low resource settings like Ghana and the rural areas where most of us come from. patients cannot even afford the CT scan to begin with. So you can't even tell whether it's hemorrhagic or it's infarctive. You can't afford most of the medication.
I think we lost Dr. Nabil.
Expensive. Thrombolysis is extremely expensive. And even amongst doctors, if you suffer from a stroke, can afford thrombolysis. So prevention of stroke is extremely important. And a lot of emphasis should be placed on that. The other observation that I want to make has to do with BP control and supportive management in situations of stroke. So we all know that most of the time, what leads to the mortality are the complications. And I'm glad that aspiration, pneumonia, and so on and so forth. So the supportive management. And here our nurses are very key. Unfortunately, some of our nurses don't do so well. Okay, that is why the ideal thing is to get a stroke unit where these patients can be adequately managed, where you have a multi-disciplinary approach. Okay, so you have a whole team there to help manage the patient. We don't have these units in most centers. So the nursing care is so crucial. So we shouldn't manage these cases like we usually do with other conditions. You write your plan and go away. We should make the nurses understand that the survival of these patients depend on the nursing care, not necessarily on the medication doctor is prescribing. It's the nursing care, the regular suctioning, and so on and so forth, making sure the patients are well hydrated, monitoring their sugar as required, and so on and so forth. That is what would determine the survival of the patient, the nursing care, until we get to a point where we have the luxury of having stroke units all over. We should drag our nurses along. So I was happy when I saw pictures of the nurse pointing out the area of the hemorrhage on the CT scan, which means we are getting them involved. So the nursing care is very important because by far it determines the survival of these patients. So the BP control, which has been discussed on several occasions, I don't want to go there. And then the supportive management, it cannot be overemphasized. Very, very important. So I mean, these are the two observations I would want to make. But so the emphasis on prevention and then the supportive management, extremely, extremely important. And I just want to add, I think in his presentation, when he spoke about hemorrhagic stroke, sometimes it's good for us to discuss prognosis. When patients come in, it's very important because the expectation, it will surprise you that the expectation of relatives sometimes are very high. So when they come in, you do your score. The various scoring systems available. We have the ICH score. The presenter didn't talk about it, but for hemorrhagic stroke, so you do your scoring systems. It gives you an idea of the prognosis, and then you can discuss with relatives, begin to prepare their minds for the worst. But the supportive care is extremely important. Thank you very much, Dr. Akatba. These are my observations.
Thank you, Dr. Nabil. You always add a very good deal to the presentation and make it richer. If you have more questions, you could put up your hands, and then or suggestions or comments, you could likewise electronically raise your hand, and then we'll mute you. Just before we do that, there are a couple of questions in the chat box, which I think we'll take now, and then go on to the discussion. So the first one was from Andani. Please, as part of the stroke management, do you consider lipid levels and its control? Dr. Michael, do you want to try that? Do you want to take that?
As part of, okay.
Yeah, so lipid levels and stroke management.
Okay. So as I mentioned earlier, in the management of ischemic stroke, irrespective of the lipid level, all patients will have to be on, either atorvastatin or the other lipid-containing drugs, because it's not only the lipid that you are controlling, because it has been found out the atorvastatin or this anti-cholesterol drug tend to cause stabilization of the atheroma. So it's not a matter of the lipid levels.
Great. So really,
1% irrespective of lipid level will have to be on atorvastatin.
Great, great. So it's one of the things that we need to highlight, especially for practitioners here, that it's unfortunate that our National Health Insurance Scheme does demand for cholesterol levels or lipid levels before you start someone on a statin, and they won't want to pay for the statins if you don't request for that. I don't know, it doesn't make sense anyway. In stroke, it is not about whether your cholesterol is high or it is at this level. We are not giving the statin basically to drop your cholesterol. We don't treat labs, we treat human beings. The reason for its use in stroke is, as Michael mentioned, but not only for infarctive stroke, but even hemorrhagic stroke. So in infarctive stroke, typically we do the moderate to high intensity statins. So you realize that like a popular professor of mine, we usually say, if you give somebody 10 milligrams of atorvastatin, you are treating yourself. So typically we are looking at high intensity statins, usually in the doses of about 40 to 80 milligrams of atorvastatin, or even 10 to 20 milligrams of rosuvastatin. So the reason for its use in stroke is not mainly about lowering your cholesterol because it is high. Even if your cholesterol level is normal, we would give you a statin. The reason, obviously, is a secondary prevention, as Dr. Abeiza mentioned. Okay, so we move to the next question, which is in the chat box. That did say, please, do you mean in case there is hemorrhage in less than 1/3 of the MCA territory, you can go ahead and do thrombolysis? I think that's from Zionite. Michael, do you want to take that?
Yeah. It should be, even if it is less than 1/3 of the middle cerebral artery, you must also consider the other, see whether if the person also doesn't have the other exceptions, especially the history of the previous ischemic stroke or the history of the hemorrhagic stroke. But this is also one of the cases that you have to consider whether it will be beneficial for the person or not, so far the person is within the time range.
All right, so obviously thrombolysis is contraindicated in hemorrhage, is that not so?
Yes, please.
Okay, so the next question was, please, can a patient present with both ischemic and hemorrhagic stroke at the same time? And what would the signs and symptoms be, and how can that be managed? Do you want to take that?
Mm-hmm. So it's like you may say, they say, never say never. But I don't know why nature would be so unfair to such a person to have ischemic and hemorrhagic at the same time. It's possible, but I have not seen one. So
yeah, so of course, like you said, it's possible, but one thing to take note of, there's what we call hemorrhagic transformation of your ischemic or your infarctive stroke. So it's for real. And of course, usually those that have bigger infarcts, we are careful with dual antiplatelet therapy because these are at high potential of undergoing hemorrhagic transformation. So it's something to be aware of. But the fact that you have probably a previous infarct does not exclude you from getting a hemorrhage. So it's, again, a call on us to make sure that once we have missed the opportunity of primary prevention, we don't miss the opportunity of secondary prevention, because once you've had a stroke, you are at 50% increased likelihood of getting another stroke. Like my popular professor of neurology, Dr. Akpalo, always say, once you've had a stroke, 50% increased risk. So it calls on everybody to run around and make sure that you are sorted out. All right, thank you, Michael. Another question says, what's the protocol for preventing DVT and pulmonary embolism in a patient with hemorrhagic stroke? Do you want to take that?
Okay. So that, not putting patient on anticoagulation, the risks associated with far outweighs the benefit. So it is, even though the person has hemorrhagic stroke, studies have shown that within or after 48 hours of onset of symptoms, you can safely put the person on anticoagulation, because not putting the person on anticoagulation for the person to develop a DVT and subsequently a pulmonary embolism is more fatal than not putting the patient on anticoagulation. So safely between 48 hours after onset of symptoms, patient can safely be put on anticoagulation.
Great. So I would call on or just recollect what Dr. Nabil did making the suggestions. Ideally, there's what is ideal, what is best practice. Best practice is that for such patients, we put them on the IPTs, that's intermittent preventive treatment, or intermittent pneumatic compression, sorry. So typically, those people, because of the hemorrhage, obviously, if you put them on anticoagulants, the risk goes up. The best would be if you have your intermittent pneumatic compressions, like we used to have at the stroke unit in Kolebu. If you do have these available, such a person can be put on. But like you rightly said, Dr. Abeiza, once it's more than 48 hours, obviously you would want to look at the risk of having a pulmonary embolism, since the person cannot move, and be sure that you are given a prophylactic dose of the anticoagulation. Okay, I think those are all the questions from the chat box. We have Nana's hand up. So I will ask you, Nana, to unmute yourself and go ahead with your insights and contributions.
Thank you very much, Senior Katiba, for the opportunity. Please, I want to ask, a patient had stroke, ischemic, let's say it's about 3 months now. The affected side, the limbs, that the hand, the leg, remain swollen. BP has been well controlled, sugar well controlled. She's been doing physio right from the get-go. By what mechanism is this swelling sustained, and how is it to be managed vis-a-vis this hand-shoulder syndrome? And then secondly, I think yesterday in the morning, a friend called, I think a lawyer who was heading to court, that he can feel the mouth, somebody just told him the mouth is twisted a little. So I asked him to pass by the nearest hospital for attention. After about 2 hours, he tells me that he's just sitting there, they are doing all sort of tests, they are not telling him anything, and they said everything is normal. The issue of a developing stroke, assuming that was it. Once the bus moves, can it be stopped? What is supposed to be done if it can be stopped at that point? Thank you.
Great. Thank you, Senior Adu, my only learned colleague. Michael, do you want to attempt any of his questions?
So, okay, I'll start from the last question. So this is a case of a developing stroke. So the issue is like, is it an ischemic or hemorrhagic, which is going on? So most of the times where the person is having just maybe asymmetry of the face. So it depends on the progress. Is it, if there's also person has maybe a speech impairment, is it improving or not? So this will help you to distinguish whether it is an ischemic process or the other. So looking at the discussion, I think it'd be more of an ischemic. So the immediate intervention was rightly to go to the hospital. So, it is sad that by the time that the patient with such symptoms will see a doctor, would even have the time that the person will spend within that period, it may even be that period may have been elapsed. So it's like taking a risk. I'll be very, very sure if it is ischemic, the person can start with the aspirin. The person can start with the aspirin, but if not, the person will quickly need to go for, I think, another hospital where there can be more attention given.
Great. I'm happy you brought this up because a very venerable senior colleague of ours, a professor in Kolebu, we did put some money down as a bet on clinical features of an infarctive versus hemorrhagic stroke. A typical presentation, like Dr. Ado said, this person we knew had a stroke, but he just wanted to highlight the fact that imaging is the way to go, like the new definition that says. It's extremely difficult to say that. And in fact, from looking at the person, back in the day, like he told us, usually if you present in a very insidious form, like you don't look hyperacute, you don't come vomiting, severe headache, with looking so toxic, they will think that if you don't present with most of these, they think that probably you are having an infarct. Versus someone who comes looking very sick, vomiting, headache, BP skyrocketing, they will think that you're having hemorrhage. But like it turned out at the end of this bet, he lost money. The person who came in a toxic looking was found to have an infarctive stroke. It wasn't a hemorrhage. And the one who looked not even sick at all, it was a big hemorrhage in there. So just to call on the fact that it's extremely difficult, if not impossible, to look clinically and say, and like the WHO definition does this, like we saw from Dr. Michael's first slide, it's highlighted that it has to be with objective evidence, imaging evidence. So that's where the problem is. All the government hospitals, unfortunately, in the 5 regions of the north, Upper East, Upper East where I come from, Upper West, excluding Upper West, Northern region, Savannah, Northeast, no hospital, not even one, has a functioning CT scan in the hospital. In Tamale, which is a big unit and expected to be, the CT scan has been down for more than 5 years, unfortunately. It's a private person who has opened a gold market closer to the hospital where he does the CTs. Fortunately, because we've had a new hospital in the Upper West, there's a CT scan in situ. So then, God forbid, but should my grandmother in the village somewhere hiding in the Upper East get a stroke, the 3 hours, the 4.5 hours, as by the trials in the United States or even the stent trial in the UK that's put in. Of course, those number of hours, I'm not sure she can get thrombolysis. So it's important that we highlight the need for some of these things to our policy leaders and all of that. It's not out of place if each regional hospital in all the 16 regions of the country does have a CT scan that is working in there, like we have in the newer hospital here. So it's the way to go. I would think that it's quite difficult saying it is either an infarct or a hemorrhage based on what the person is presenting. And the way to go, obviously, is to confirm that this is not it or this is it. If it is, like we know in the hyperacute management of stroke, thrombolysis is the way to go, where you have an ICU setting. In Kolebu, there were a few success stories. I got into the Upper West and I was surprised that a new 7-bed ICU is available with intubation and all of that. We had only 3 beds in Kolebu, and we have an emergency physician in the hospital. So really things are going on well, if only we look at pushing our policy leaders to do the right thing. I will always say that if you had each region having a facility like this and people accept to go to the rural hospitals to work and forget about the monies from locum and all of that, it will help in a way to save the future generation. I won't want to be the one, nobody wants to be the one. So the discussion can continue. Dr. Nabil's hand was up after Dr. Adu. So Dr. Nabil, I guess you wanted to add on something. Please go ahead.
Yes, boss. Boss, thank you again for the opportunity. But it's with regards to the question posed about how we would proceed in the presence of both infarctive and hemorrhagic stroke. And I think the point was made, but I want the questioner to appreciate that didn't come out so clearly. You manage as hemorrhagic stroke. So when you have an infarctive and hemorrhagic, you manage as such, because I'm guessing he's probably thinking of his antiplatelets and so on and so forth. And so I wanted that to be highlighted clearly. So when you have both hemorrhagic and infarctive, you do not give your antiplatelets. And like Boss mentioned, in cases of large infarct, you can sometimes have hemorrhagic transformation, in which case we would also withhold the antiplatelets. In fact, when you have large infarctive stroke, you do not even start antiplatelets at all. So when you have infarctive strokes that are larger than 1/3 of the MCA territory, it's advisable not to start your antiplatelets at all. So the point is, you manage as hemorrhagic stroke when there's evidence of hemorrhage, irrespective of what is going on elsewhere. You manage as hemorrhagic stroke, and you withhold your antiplatelets and so on and so forth. Okay, yeah. Thank you, boss. Just wanted to highlight.
Great. Thanks a lot for bringing that up. So, Dr. Adu, I don't know if you are okay with the response or you have any further to go.
Yes, Senior Katuba, I think that my questions were two. The other one was with where the affected side has a sustained swelling for months. The upper limb, the lower limb, they are also swelling. A lot of physio has been done, and vitals are all normal. Everything is well controlled. I wanted to know by what mechanism this is sustained and how to manage that.
Yeah, the number one thing I would like to rule out regards swelling at an area of an infarct or an area of hemiplegia or hemiparesis. It's ruled out Cardinal Syndrome. And this is for real, especially once we are doing physiotherapy and all of that. Because, of course, the thinking is usually that once that hand or that leg or the hemiplegia, if you don't start the physiotherapy, then you are likely to have some atrophy. And so if this is in the setting, then you would want to be careful about. But as to the mechanism, as to the mechanism underlying why you have a swelling in that side, I'm not so clear about that myself. Anyone who wants to offer such can, or if Dr. Ado, you want to have a further, you want to throw further lights on it, kindly do as well.
Yes, Sinakatuba, actually, the physio was started right from the beginning. Physio was done right from the very beginning, but then the hand remains swollen, the leg, the foot there remains swollen. Elevations are being done, all sort of consults have been done. Renal function is good, liver function is fine, no cardiac issue. And the other leg is fine. The unaffected side is just fine. So that has been a bit difficult getting around with. Yeah.
Yeah, that's difficult to say, unless probably the clinical examination does lead to any match.
Okay. The other question I wanted to ask had to do with the hyperlipidemia control. In strokes, yes, we give high dose statins to control, and then you mentioned a continuation to prevent the secondary prevention. While secondary prevention is good, the question is, should it still be with such high dose statins as was given from the beginning? Because a lot of material also abound, suggesting that the statins contribute to some of the swelling. And I've had the opportunity to review quite a few materials. But then the protocol remains that once it's been stroke, you maintain the high dose statin, even when the lipid profile returns normal. And I wanted some further clarifications on that, whether it's time to review that. Thank you.
Great, thanks. So like a very popular trial, which is worldwide, and most people usually quote in the management of stroke, called the Sparkle trial. I think this was published somewhere in 2006. It was the landmark study in usually vascular neurology. And this demonstrates that I think there's some bit of background sounds. I don't know where it's coming from. Let me mute Dr. Ado. All right, sorry about that. So I was talking about the Sparkle trial and its worldwide evidence that has shown or demonstrated that high dose statin prevents recurrent stroke. And this was actually led by no other small organization than the American Heart Association and American Stroke Association. And they recommend the high dose, high intensity statin for patients with stroke or even TIA of atherosclerotic origin. We can probably go take a look at this. Back to your question about its use, especially, of course, statins, one of the common side effects that we're aware about is their hepatotoxicity. But again, recently, like we had a high-level discussion in one of the morning meetings in Kolebu, the gastro people did indicate that this is overrated, and people sort of would typically be afraid to use statins because of probably just the liver enzymes that are a bit elevated. As much as usually we'll say, if it doesn't go beyond 5 to 10 times the upper limit of normal, you will not be so much of a problem. But the other muscle issues are for real. And like the patient you did describe, if I had such a patient with the muscle swelling, muscle spasms, myalgia, and some musculoskeletal pain, I would look at reducing the statin, especially in that setting, or I have the liver enzymes that the ALT that is skyrocketing there, then obviously we have to look at that in that regard. So it's in the clinical context in which you may need to reduce the dose or stop it entirely. But as for its use in ischemic stroke or even moderate doses in hemorrhagic stroke, it is of worldwide evidence. The American Heart Association, the American Stroke Association is embedded there as seen from the Sparkle trial. So is there. The main reason is actually to prevent recurrent stroke. And so typically the person is going to be on a high intensity statin. Any more questions, comments, suggestions? Dr. Ben, I saw your hand was up. If you want to, please take a go. Dr. Kinkang.
Hello. Yeah, thank you very much, Dr. Akatiba. Please, I wanted to find out from Dr. Ado whether the swelling, was it some form of edema or what kind of swelling was it? And if it was edema, was it peaking?
Oh, hello, Ben. Hello. Hello.
Yes, Dr. Ado, we can hear you, sir.
Yes, it's in the form of a swelling. It's actually a swelling. Yeah, it's an edematous, yeah. And typically when she sleeps and elevates the legs or after in the mornings, it's not there. It goes away. But later it comes back. Both the hand and also the leg, yeah, the foot.
Yeah, so usually for stroke patients, sometimes there's an associated loss of vascular tone. And then when there's a loss of vascular tone, there's going to be local vasodilatation of the vessels at the site that is affected. And then we expect that if the muscles were working, were active, the muscles will be able to pump the blood, the venous blood up. But here's the case, the person's legs are paralytic and the muscles are not working. So that vascular dilatation becomes sustained and progressively becomes bigger. So if that is not well taken care of, it can lead to that possible swelling that you noticed. That is a possible explanation, but I'm not saying that is what has happened, but it could be another explanation for that occurrence.
Great, Dr.
Very well.
Ben.
Very well. Yeah. Thank you, Ben.
Great.
All right.
Okay, so any more? I think there isn't any much in the chat box, and I don't see any hand up.
Someone is asking,
Okay.
how the management of a patient with IVS 1.2 and a stroke with a clot B, since the stroke is contraindicated? So I think in this scenario, hypoglycemia will kill the person faster than even the stroke. So even though the person is having a stroke, I mean, the strokes that we mentioned to be contraindicated is for people with normal blood sugars, but not people with hypoglycemia. So you tackle the hypoglycemia aggressively, and then make sure that the glucose is within the 7.8 and the 10, and not exceed. Then you can start with the normal slide.
Great. So are there any more, or that's all? Let's just go through. Okay, right. So there are a few others. So someone mentioned Tamale CT scan is now working by God's grace, boss. Yeah, so that's great news. That's good to hear. So we are informed that the Tamale, I hope this is the one in the hospital, because when I was there was CT scan, but this is that was the one at the private man's place. But if the hospital one is working, that's excellent, because then it will reduce the cost as compared to the private, how much the private man is charging. Emmanuel was asking, please could you highlight on the use of acetazolamide and tranexamic acid in hemorrhagic stroke? Okay, and there's a second part. Please, any benefits with the use of cerebrotonin or citicoline and fluoxetine in ischemic stroke? Very great questions, and will bring a lot of controversies as well. Dr. Michael, do you want to start it off?
Okay, starting from the last question. So, in fact, those neuroprotective agents, the cibotonine, citicoline, many studies have been done to see whether they improve morbidity or mortality, and such findings found negative. So, if the person is on it, it's not a true assurance that it's going to really improve the condition. If the person will improve, it may not necessarily be the citicoline or the cibotonine. So it's like taking in food supplement in general. Food supplement for a disease or malnutrition. The food supplement may not necessarily solve the underlying cause of the malnutrition. So you have to tackle it. So they are good to be used, but not with full assurance that they are going to improve mortality. So if you are managing a patient with stroke, we need not to stress their pocket of buying citicoline or cibotonine with the idea that it's going to improve their symptoms. So myself, I was thinking so, but I read through several articles and saw that it doesn't really improve. And
okay. Yeah, please go on.
And then with the first one, use of tranexamic acid. So the underlying issue is that there's a bleeding going on. There's a bleeding going on. And then tranexamic acid actually, even though it's used for mucosal bleeds, but it doesn't really stop the bleeding sincerely. So even though it's like you are not, in the case of stroke, you're not giving medication to stop the bleeding, but you want to tackle the cause of the bleeding, which most of the time is the hypertension. So giving tranexamic acid instead of controlling hypertension, it's rather way that you are ending up in hell than any other form of management. So it doesn't, tranexamic acid is not really applied in management of stroke.
Great. The last bit was on acetazolamide. You want to try that?
So in my reading, I didn't come across it most of the time for management of the intracranial pressure at the monitor and all the normal the hypertonic saline. Didn't come across that.
Great. So just to even make it more interesting, you'll find that even in Kolebu, we use acetazolamide and mannitol. Sometimes, of course, when there's what do you call that one? Extension of the hemorrhage. So intraventricular extension of the hemorrhage. So typically, maybe, but the evidence for acetazolamide is there and the jury is there, so you could look at it. The main reason is by lowering the intracranial pressure, because typically, like we know, the acetazolamide does inhibit the sodium potassium ATPase, and so it slows typically CSF production. And by that way, by decreasing the amount of CSF secretion, of course, you would be able to reduce the intracranial pressure. And where you have an intraventricular extension of your hemorrhage and all of that, it may be of place. The evidence for sugar, mannitol, those hyperosmolar agents is more of an expert consensus or expert advice. In Kolebu, it was a common thing to see that we prescribe mannitol and acetazolamide. I don't know if that has changed by Dr. Nabil, Dr. Lukman, who are residents in Kolebu. Any highlights on those?
That can weigh something like a 10.
We have the smaller scales. I don't know whether it's
the one for babies. The one they could.
All right. So that's
ones. That's
it
the one.
with regards to that. Yes, Dr. Lukman.
Thank you so much for the opportunity. I think the presentation was excellent. And regarding what you asked, yes, so we still use the acetazolamide and then the mannitol, but then there should be evidence, like you said, of increased intracranial pressure before you use those. So it's not a routine that once patient is diagnosed of hemorrhagic stroke, you would use it. If there's evidence that the patient has increased intracranial pressure, then there's some benefit in using it. And the trials that they did on the other agent that they asked about, the tranexamic acid, showed that it really didn't improve the outcome of the hemorrhagic stroke in using tranexamic acid. I think there was a trial, I've forgotten the name of the trial. It didn't show any benefit. So actually, it's not advised in using that agent. That's the little contribution I wanted to add. Thank you.
Great contribution. So it's out there. Now the other things are the so-called neuro protection agents. That one. So this is it about citicoline and paracetam and all of that. It's difficult. So for citicoline, actually, the results were not statistically significant. But those who did the trial were quick to add that the bar was overset and such that there was a bit of improvement, but did not meet the high set bar by they themselves. So it's not here, it's not there. If anxiety is there, if the money is there to be able to afford that, in the midst of nothing, what do? You can usually throw in that. But the evidence, if you are practicing evidence-based medicine, you won't find that in the American Heart Association, American Stroke Association recommendation for such agents. But like, of course, when there's something small or a minor benefit, you can usually throw in something to, of course, in the midst of anxiety where there's no negative effects of it, you could do that. But in terms of evidence-based medicine, it was not statistically significant. Now, about the issue about fluoxetine. Fluoxetine has been shown to have some improvement in stroke, especially with those with depression. Various trials. You have the FLAMES trial, you have the HOPE trial, you have the EFFECTS trials, amongst others, which did make clear recommendation. Unfortunately, these trials did not provide significant evidence to support routine use of fluoxetine for stroke patients. So that's something to take note of. The Flames 2 trial did show some improvement for 3 months of use. But typically, like we were doing at the stroke center, what you do is if there's depression or there's, depression is for real in stroke, you know. So if it's there, post-stroke depression, you can use these SSRIs, such as fluoxetine, to improve both the functional and cognitive outcomes. And this will reduce the mortality. Since we are talking about stroke and depression, one of our usual attendees, Dr. Joel Agorinya, I think he sent a message to me that I should try and draw the attention of the audience to the neuropsychiatric sequelae of stroke, which include depression, just like we talked about, anxiety, mania, vascular dementia, and pseudobulbar palsy, as well as the post-stroke seizures, which we are aware of, and psychotic disorders, including various forms of perceptual abnormalities. So it's important that stroke management is a multidisciplinary team approach. So we always say that. Somebody was asking about, can you combine aspirin and clopidogrel in the management of ischemic stroke? I think Dr. Michael did great justice to that one. And you have to be careful with the extent of the impact. So the evidence for dual antiplatelet therapy was for those who had minor strokes. And this is used for 3 weeks only, and then you continue the single antiplatelet therapy. So like we always say, like Dr. Nabil and other people highlighted, you see, if the expertise is available, it's not the best to keep the patient in your local hospital. Once you are done with the acute issues, i.e. stabilizing the blood pressure control and all of that, move him to where there can be a multidisciplinary team approach rather than in a single hospital where you don't have a physiotherapist, no clinical psychologist, no nutritionist, or even a CT scan to be able to tell which the difference is. So usually instead of having to manage this person chronically, it will be better to find out what type of stroke it is. And then even if the person cannot get into that great 3 hours or 4.5 hours, he should be at where he'll be able to have the benefit of a multidisciplinary team approach. We cannot overemphasize that. And someone is asking about the ideal doses for the dual therapy. Again, a quick one that if you are doing dual antiplatelet therapy, it will mean that this stroke is CT scan confirmed to be infarctive, and it is confirmed by CT scan again to be a minor stroke or a smaller size infarct. So this is where then you can throw in that. And if it is, then the 75 aspirin, 75 of the clopidogrel. Otherwise, if you cannot say so, someone has a bigger infarct and you go through this, you kill the person. So let's please take note of it and do the right thing. So I think those are all the questions from the chat box. And Dr. Ado, is it from the previous one or your hand was up again? Okay, I guess it's probably from the previous one. Today we've spent about, yes, sir.
Yes, it's not prepared, just something brief.
Okay.
It looks like we haven't won, especially when it comes to stroke management, we haven't won the war of hospital management of stroke over what herbalists, herbal treatment, traditions, whatever, are pushing into the minds of people. In fact, at the Confanochi gate, a hospital secretary and a midwife stopped me and told me about a place where just 1 month strokes are treated, whatever herbal it is, and that we are wasting people's time. The difficulty is not necessarily the truth in what they say, but the amount of patients they are able to pull to these places. And by the time they return, get back to us, things have deteriorated that bad. Just for me not to be hasty in my conclusion, I just want to ask colleagues, has anybody, and I think these days we have some of these herbal departments in some of our regional hospitals, etc. Has anybody has any experience where a stroke patient was referred to any of these places and there was any particular herbal treatment we can all vouch for that it is safe and that we can refer our patients there? Because the confidence and the extremity with which they speak to patients, we lose patients from the walls all the time because they've heard that's where they have to go. Thank you.
Thank you, my brother. You are not alone in this. And it is not only in Konfanoche or Kolebu, where also in Kolebu, just opposite the hospital's main gate. About that, there's a very big Chinese herbal hospital there. They promise a cure for stroke. In the Wa Regional Hospital, far away from the south, just closer to the hospital, next gate is a very big herbal hospital. And they are also promising a cure for stroke and for you to walk shortly after the stroke. They even do very funny things like acupuncture and all of that. For me, I speak for myself and my household. I don't have any of such evidence that somebody has had a stroke and gone there and recover. But I've quickly seen that Dr. Lukman's son is up, Dr. Nabil is up. Maybe they have a herbalist who has cured the stroke. That's all here, and then we can turn our patients there. But for me, as for me and my household, we will serve the greater medicine.
Yeah, boss. Thank you for the opportunity again. But you know, when I wanted to mention it, but because I thought that, I mean, that's not an issue now, because we all know that these herbalists and the kind of things they always anticipate for and the kind of confidence they exude when they are selling their medicines. But the experience I can share is just recently, a colleague of ours, even though, I mean, I can't mention names and all that, but a colleague of ours fell sick. I knew he had hypertension and all that. And then we're managing the BPs. But somehow, he stopped taking the medication and then resorted to some home remedies. And then the mother passed of stroke. And then just some days after the funeral, he also fell sick. And then they called me. So I noticed that there were symptoms of stroke. And funny enough, they decided to, they went to the hospital, did everything. And then it came out that truly he had a stroke. They gave them medication and all that. But they asked for discharge from the hospital. I was actually trying to see if I could get them, like you said, once they stabilize them, let's get a specialist, the multidisciplinary committee will come in and then decide on the way forward for him and all that. But the family decided they wanted to take him home. And I knew when they said they want to take him home, it's herbal they want to go and do. And truly, they went to do herbal. And then I texted a brother that he should send me the medication that the herbalists have put the patient on. And to my surprise, they kept the patient on the same medicines that, they gave him amlodipine, they gave him furosemide, they gave him citicoline. And I was wondering, what business do you have to be having these medications? And furosemide, when the patient was not even in any form of heart failure or anything, they were giving all sorts of. So it's like now, so I just fine-tune, and their mindset was that the patient was even doing well on those herbal medicines. So I told them that, well, these are not herbal medicines. These are our own drugs. So what I suspect is that either, number one, they have studied the medication we are giving, and they are kind of also paraphrasing, or if I'm allowed to use the term, prescribing. or some of us probably are telling them to do this and do that in their facilities. And instead of encouraging people to come to the hospital, they rather sit there and will be doing some form of half. They will do half herbal, half orthodox. So it's really a problem. And unfortunately, the guy passed. Very young guy, health worker.
Oh.
He passed of stroke, which could have easily been managed if he was probably taking the antihypertensives and all that. So as for that one, it's a real problem. It's really a real problem. But as to what the way forward is, and recently I hear, even in the hospital setup now, because of their advocacy, the herbalist advocacy, now in every hospital, they are supposed to have a department for herbal treatment as well. So if a patient comes, you, the doctor, have no right to tell them that herbal will not help them. You should rather give them the option when they want to go for the herbalist or they want to go to the orthodox.
That's unfortunate.
Yeah, so
Very.
actually I said that now, if anyone has more insight into that, but that the Ghana health system setup is now something that is allowed, that in a hospital setting, when they also finish their course, they come to the hospital, they are supposed to be given a consulting room. And if a patient comes, they are supposed to give the opportunity to the patient to either access the orthodox or the herbalist. So that's where we are as a country. Instead of us to probably promote what we have evidence for, we are rather going for things like that. And it's a real problem. And like maybe Dr. Akatiba is saying, he and his family, they are for orthodox. So maybe in our own small corner, we should encourage our near relatives to go for orthodox. That way, probably the light delighted everyone.
I practiced before I left to specialize. Dr. Adwa and I were in the then regional hospital. I think there was a room for the herbal medicine person. But it was quite instructive that I think he used to, those cases that were beyond, of course, the remit of herbal medicine, like stroke and all of that, herbal Dr. Ofori used to send over.
Yeah.
But for me, I think the bigger challenge is not even those who are regulated in the hospital setting, because I from my interaction with him, it looked like he knew what he was about. There were things like stroke he would not lay his hand on. But obviously, the unregulated one, which is even more powerful, is super powerful, more than anything. And they promise the cure. They will tell you that I'll cure you. And you drink the medicine, the clot will break or the clot will melt. I always ask whether the clot is a metal, because the only thing I understand, things that melt are metals. So if you say the clot will melt, I tend to ask whether they put a metal in place of the clot. But that's the reality of it. And it's sad. I'm happy that Dr. Adwa has brought this up, because it's really something that we are battling with, and not just for stroke, but for a lot of things. So it's important, and we just have to keep the advocacy, because when at the end of it, when they cannot, they bundle you back to Kolebu or back to Confornoche or in our local place, they'll bundle you here, and you end up in the hospital. They are quick to wash their hands off that they do not cause any form of disease. The hospital that ended your life, you see. That's the sad bit of it. It's sad. Dr. Nabil.
Yes, boss. Boss, thank you for the opportunity. So maybe I'll start off with the latter bit about the influx of herbal practitioners and all of that. You know, it's really a time bomb. You know, for me, I see it as a time bomb in our health system, and I'm glad Dr. Ado raised the issue. So it's something that Ghana's health service has to look at. I don't know why, as a country, we keep, excuse my language, but we keep accepting mediocrity and all of that, and we allow it to get out of hand, and we only rise up to sort things out only when the situation is terrible. You know, so boss, even for those who are regulated within the service, there are some of them who go overboard. You know, when I was a director of the hospital at the time, I had serious issues with some of the herbal guys. I had to, give them a stern warning on the way some of them were going about certain things. You understand? So there are some of them that are actually going overboard, you know, with the use of these herbal products. And unfortunately, a few people have suffered as a result of that. I had a child who came in with status epilepticus, only for me to be told that the child was seen a few days prior to presentation at the OP. It was managed on herbal medication, and unfortunately things go out of hand, and so I think it is something that we really have to look at. Not only, of course, not only for the management of stroke, but for the management of medical conditions in general. It's really getting out of hand, and probably those of you in higher authority who have some influence can help with the situation. I know at the new regional hospital, there isn't any such department. But this department in the smaller facilities. And unfortunately, unlike the practitioner you worked with years ago, some of them now are over enthusiastic and they want to go overboard with what they practice. I would want to add that there are some who are even more malicious with what they do. Dr. Lukman mentioned that someone was giving prescriptions of amlodipine and others. Some are even dissolving these tablets in their herbal preparations. So that is what some are also doing. So you come in, they dissolve aspirin, they dissolve all sorts of medication in the herbal concoction and tell you it will improve your symptoms. Of course, when you take these drugs, you might see a bit of improvement, but at the end of the day, it worsens the situation. And like you rightly said, they end up in the hospital, and unfortunately, most of them die. So I think beyond putting in our efforts in the consulting rooms, a lot has to be done outside the consulting room, because sometimes we need to prevent some of these things. There's a lot of mess and rot in the system, and it's like the system is just waiting for something to happen. The annoying thing is that these people, they know where to go to when they're in trouble. They know the doctor to call. When they're in trouble, they know who to see. And the fate of the ordinary Ghanaian has been left hanging. It's a very sad situation. But this is just what I want to share. But boss, I think it is something that has to be looked at. The influx of these things in our system, to the extent that our government hospitals are supposed to allow some of them to practice anyhow. And it gave some of us a lot of headache when we were up there.
All right. Yeah, great. Well noted. Dr. Adu, I guess the problem is bigger than you thought.
Exactly, my brother. Exactly. And I'm so glad for the insight shared by Dr. Nabel. Indeed, it is. And I remember during our induction some years back, Dr. Ken Abua, who was the person who gave us the ethics lecture, said that is an aspect of our jurisprudence waiting for somebody to take it to court. Because all these conditions they are treating is clear in our Public Health Act. They are not supposed to. A lot of drugs are now being advertised on loudspeakers in the community, whatever, is it communication, whatever. They are always blasting this loud. They are treating it in order. It's clearly in the act that these are not supposed to be advertised and they are not supposed to treat this. It will surprise Dr. Nabel to note when you talk of them mixing this amlodipine, in fact, this Viagra and all that in their erectile dysfunction medication. In fact, some of them have gone ahead. I don't know how they got access to our standard treatment guidelines. They photocopied certain portions of which drugs to use, which to mix one in their medications. So they take some of these things. Half knowledge is dangerous, even more than ignorance. They mix them up in all sorts of concoctions and they give it. It's very true. And I hope one of these days, such a strong action will be taken to serve as a deterrent on all these things. Thanks so much, sir. Thank you.
Thank you. Thanks for bringing this up. Fantastic. Ima's hand is up. Please go ahead, and then we can call it an evening. It's been long. Ima, please, you could unmute yourself and go ahead.
All right. Thank you so much, Emmanuel Corner.
Oh, okay.
Yes, I want to thank you very much for the opportunity. Yes, my brother. It has been a long time. I must say I have actually enjoyed the meeting and you are helping us a lot. But then this issue that has come up that I just want to speak to, I realize a lot of us are lamenting over the situation. If we keep lamenting, unfortunately, excuse me my words, it may not address the situation. You realize that these people have documented evidences of people they have treated and they have been cured. And some of those people actually come out to testify of how their condition was worse and some of them were admitted in some of our public institutions, and they were given orthodox medicines, but things didn't improve until they went to them and they used their so-called medicines and were able to cure them. And sometimes when you trace, you are able to find evidence of them having actually been admitted in some of our facilities. So they have all these documented evidence that they are able to use and bring before policymakers. And when they look at it, the facts are available before them. Then they are able to take decisions and say, okay, if they can do this, then why don't you just regularize them and let them be in the system? So if we have also identified that this problem is becoming so serious, and we realize that they are actually not using herbs, but using the same orthodox medicines and mixing it with some other things, then let's have documented evidence of what we are saying. Then based on that, anytime there are bigger fora, we can come and make a presentation, and that will gradually inform people in management positions who can take it up, and then gradually things will be reversed. If we don't document it and put it across, and we only lament amongst ourselves, I am not too sure if it will go anywhere. So thank you so much. That's my little contribution. And I'm sure maybe the organizer, maybe going forward, all of us can see what we can do to put it forward.
Great. Thank you very much. That was great. I'm happy that you just hit the nail right on. Of course, if we keep lamenting of what you said. I remember somewhere, I think 2018, if my memory serves me right, in Kolebu, we had usually on Fridays, we have like the residents in training usually do a presentation. So one of my colleagues presented on a case, terrible, very bad, a case where this herbal practitioner was using, what's the name of it? Dexamethasone. So he will grind dexamethasone inside his herbal medication.
Wow.
And of course, like you, I tell you, we lost that patient. This man's side place was closed down because that presentation, the FDA and other people were involved. What's the name of there's this regulatory institution that regulates them, just like the way we have. HIFRA is for the Orthodox guys. The unorthodox guys, they have another guy. So those people were invited, and they closed down this place. Just like people would have seen in the recent expose by Manasi Azuri about a physiotherapist who is not a physiotherapist and was doing other things, and where his place was closed down. If we don't highlight these in bigger fora, obviously it won't be. So that one served like one of the case series where they used to present the evidence for it. Unfortunately, like Mr. Corner rightly said, the policy leaders, most of them are not clinical staff, and so it's difficult to say. I remember back then when Courage Kwashiga, he so rest in peace, was in charge of the Ministry of Health. I think that was when the herbal business came booming, because they had actually created a part in the ministry for them, and there was legislation to them having it in health facilities and all of that. I don't have a problem with like practice which is regulated. What is not regulated, what is not approved, like even medical school were sent to the Mampong Center for Scientific and Industrial Research, I think, to spend about, I don't know, there was a month or so, learning about herbal medicines. And this was a place that you could see that they have toxicological studies. They will undertake the herbal medicine through rigorous, of course, processes before it stand out. Even some of us ended up buying herbal medicine from there. Of course, but it's unfortunate that that's just a very tiny thing compared to what the real job is. So most of them are not really licensed, not approved by anyone, and so it becomes a problem. I think it's a bigger discussion for another day, and we really need to look at this. And it's good that at least we brought this up, because in the context of stroke, these guys have really caused us a lot of pain and a lot of harm. Dr. Ado, will you want to have the closing remarks for the herbal side so that we can close off?
But I think a lot has been said, a lot has been shared, and I'm really grateful for the insights shared by others. Going forward, I think we all know what to do. We'll take all these things seriously and inform ourselves and the necessary documentations that
so that in such a bigger forum like this or elsewhere, when we get the opportunity, we can all put something together and use it to inform policy. Thank you very much, sir. I'm grateful.
Okay, thank you very much, Dr. Ado, for that. Just to finish up, I think someone could have seen in one of my rotation, mild ischemic stroke patient given 300 milligrams aspirin start, clopidogrel 300 start, and continue on 150 daily and 75 daily for a month. I would like to know whether there is some basis for that or whether it's evidence-based. Yes, so what I know and what is in the guidelines from the American Heart Association, American Stroke Association is usually the start dose of 300 is fair. Some places do 325, so depending on the country that you are in. And following that, the dosage decreases to the 75 milligrams. In America, I think they use 82 milligrams, if I'm right. So of course, it just depends on the country that you are in. So they will start off on the higher descent and then go down. But the thing about stroke is that, yeah, of course, you said mild ischemic stroke. So it does answer the question in context. But we have to be careful that it is not a general thing for all strokes. Once this has been confirmed to be a mild or an infarct of a mild volume, then you could go ahead to do this. So thank you, Dr. Georgina Penton, for that great question. In conclusion, we just want to thank all of you for joining us today. It's been long, but I think it's worth it. We've done 2 hours, 45 minutes, and we had a lot of the discussion post the presentation. I cannot but to thank Dr. Michael once again for a brilliant, fantastic job done. Kudos to you and for all the effort put into this presentation. We are grateful that you made time as well, the participants, to join us, and more importantly, to share your insights, to ask questions, and to make comments to make this presentation more interactive. We are grateful for your time and for the opportunity that you've given to us to come into your homes, your offices, and your workplaces. This has been recorded, and like you saw in the chat that I put in, if you want the version so that you want to go through it, you can send a request message to the number I put up there, and then we'll forward it to you. Just by way of announcement, next week, we won't be able to have a presentation because we are in Sunyani for Ghana Medical Association AGM, and it's an election time. I know who I'm voting for. Dr. Ado knows who he's voting for, and others. So let's make time to be there to change some processes which definitely need to be changed. And hopefully the week after then, we'll resume with the presentations. We are grateful for the time. God bless, and take good care of yourself. Like the World Stroke Day says, I don't want to be the one, so don't be the one to have a stroke. Stroke is preventable if we do the right things, and more so, if someone has it, we can have a secondary prevention of stroke. Please take care, and God bless all of us. Bye-bye.